Youth. And thank you for joining us, and happy Pride Month. Quick reminder to those of you again who've just joined to please mute your Zoom screen, and we will obviously have the opportunity later through the question sessions, which I'll explain, to answer any questions you might have or any comments that you would like to put in the chat room. Quick housekeeping note that today's presentation is supported by the State of Connecticut's Office of the Chief Public Defender and the Center for Children's Advocacy. Most of you may know, but some of you may not, is the largest legal advocacy center in New England that's exclusively dedicated to children's legal rights. Our work is in various circles: abuse and neglect, racial justice, educational advocacy, immigration, youth homelessness, juvenile justice, health equity, and disability rights, and other areas. And our offices are in Hartford, Bridgeport, and New Haven. I want to go over a few objectives of today's presentation because of the unique nature of this particular seminar and its kind of ever-changing world of both healthcare and legal rights. But this is our introduction to this particular issue for our work in the field of children's and
I guess this is it.
Thanks.
teen legal rights. Just a quick reminder, please mute your screens if you log on. And so we have really four main objectives today for this presentation. Number one, to provide background and context on the present state of legal rights of teens and adolescents. So a brief overview of the basic legal rights of teens, what teens can consent to, and what they have the right to confidential care for in Connecticut. To enhance all individuals' knowledge of the concepts of gender dysphoria and gender-affirming care. To increase the knowledge of how the unique healthcare needs of adolescents, LGBTQ plus youth, are viewed in a behavioral health clinician's viewpoint, and the specific tools available to provide support and behavioral health interventions to this population, and to increase a wealth of knowledge of resources for healthcare access and availability for LGBTQ plus youth. Some quick logistics before I introduce our presenters. All participants, again, please should be muted. Please put any questions in the chat. We'll save them for the end or during the presentations, if appropriate, to break in and provide some context based on those questions and chats. So please, though, don't hesitate to post them during the entire scope of our presentations. And finally, as you can probably see when you logged on, this webinar will be recorded and available on our website at a later date. So without further ado, I want to introduce our presenters today. The first presenter that you will hear from after I give a brief overview of the legal state of the law in Connecticut is a dear friend and colleague, Dr. Alyssa Bennett, who received her bachelor's degree from Skidmore College and medical degree from the University of Vermont. She completed her pediatric residency training at the Connecticut Children's Medical Center, followed by a fellowship in adolescent medicine at Boston Children's Hospital. She returned to Connecticut Children's in 2016 and became the division head of adolescent medicine the following year. She's an assistant professor of pediatrics at UConn School of Medicine, specializes in teens and young adults with eating disorders, menstrual issues, and contraception. And we are thrilled to welcome Edgar Scott to the panel as well, who is a board certified art therapist and a licensed professional counselor and a national certified counselor as well. They are the founder of Lux Knox Counseling Services, and they have also worked at the Village for Families and Children for almost 4 years. Edgar holds a bachelor's in psychology and a bachelor's in fine art from the University of Southern Indiana. as well as a dual master's in art therapy and counseling from Albertus Magnus College. Edgar has dedicated their career to building a stronger LGBTQ IA2S+ community through therapeutic services, education, and community outreach. At the Village, Edgar provides individual, family, and group therapy and is chair of the Pride Committee. They are co-chair of the Diversity Committee, a member of 2 staff engagement committees, and provide training and education regarding working with the LGBTQ IA2S+ community. So I'd like to take everyone a quick step back. Those of you who work in this field probably are very familiar with the landscape of what teens have the legal right to consent to and what is in that gray area. But I think it's always important to talk a little bit about the actual legal rights that teens have and what is statutory in nature and what is a little bit more amorphous, perhaps constitutional, or even in that more significant gray area. So to take a look at those specific rights, I want to take you back to the basic definitions, all right? And the first one, to remind everyone, is that a minor is considered anyone under the age of 18, except as otherwise indicated. So by statute, a minor is considered any individual under the age of 18. Now, the specific statutes that provide minors the right to care confidentially with the ability to consent that consider 16 as the age of majority, specifically the Connecticut abortion statute and the inpatient mental health statute. But in general, the general rule is that anyone under the age of 18 is considered a minor. Why is that important? Because an individual who is not an adult, who is not considered of the age of majority, does not have the legal capacity to provide informed consent. So a minor, in general, cannot sign an informed consent piece of paper or acknowledge that they are legally capable of providing that informed consent. That's important because absent informed consent, a medical provider is not at law appropriately available to provide medical care. And that's anything from a rather mundane primary care visit all the way up to a significant procedure. Now, obviously, that does not apply in an emergency situation, but the general rule applies across the board that if you're not of the age of majority, if you're not 18 in Connecticut, you are not legally capable of providing informed consent. Now, some folks in other states and in Connecticut may have the impression that there is this opportunity to present as a mature minor. And that by definition is an individual, a minor who exhibits the maturity of an adult and can make decisions regarding their own medical care. But keep in mind that Connecticut has not recognized the mature minor doctrine. Connecticut courts have made it explicitly clear that they have not recognized the mature minor doctrine. The legislature has carved out the opportunity for 16 and 17-year-olds to seek an emancipation order. But in general, minors are not mature, even if they present as mature. They can be evaluated as being independent. They may be parents, but that does not make them a mature minor because the courts have not recognized that. And that was last affirmed in the case of Cassandra C. a number of years ago, that the Connecticut Supreme Court denied a minor the right to make decisions about refusing life-saving care for cancer treatment. And the court basically said, we're not going to recognize that at this time, perhaps sometime in the future. But at this time, the structure that the legislature set up for emancipation and federal scenario where minors must be adults 18 or over to make informed consent decisions will still apply. So what can minors consent to at this point in time? This is the list of areas where minors are generally recognized or have statutory rights to provide informed consent in daily treatment. And those revolve around certain reproductive healthcare issues such as abortion, the care and treatment of sexually transmitted diseases, the testing and potential treatment for HIV and AIDS under certain circumstances, the availability of PrEP, pre-exposure prophylaxis, as a intervention, also by statute allowable, mental health treatment, both inpatient and outpatient, and substance abuse treatment. Those are statutory rights that are given to minors, with some caveats, without getting into too many of the details here, but with some caveats that minors have an unequivocal right to care and treatment and may make those decisions confidentially and in a scenario where they have the legal capacity to provide that consent to treat. Birth control, contraception, is also a constitutionally recognized principle that has emanated from the Supreme Court since 1964 in the landmark case of Griswold versus Connecticut. And as far as we know, and as far as we can see, that law is still good law. It has not been addressed by the Supreme Court, unlike Roe versus Wade, which was obviously overturned a year ago and left to the states to make decisions. Contraception appears to continue to be an unequivocal right of individuals, and through other cases that have been decided by the Supreme Court, also for minors as well. But it is not a statutory right. So if for some reason the states decided to prevent or preclude minors from contraceptive availability or access, that is a possibility, although not likely, and we have not seen that yet. So taking that a step further, just so we have a little bit more clarification regarding this particular reproductive health issue after the Dobbs case. As I said, abortion, sexually transmitted disease treatment and care, HIV and AIDS, certainly testing and then potentially treatment, the availability of PrEP, are statutory rights in the reproductive health realm. Those are unequivocal, and minors have the statutory right to seek confidential care. Contraception seems very solid at this point in time. Supreme Court has not acted on that issue, although there's some implication that it might decide to do so in the future. But as of now, I think it's a pretty safe bet that contraception is a ironclad guaranteed right for minors. Pregnancy is a little bit more in the gray area. It is our contention and many advocates that pregnant minors do have an unequivocal right to make confidential decisions about their care, but that is a little bit more in the gray area and falls a little bit more under the umbrella of reproductive rights rather than a specific right granted by the US Supreme Court, such as contraception in the Griswold case. But for the most part, I think most providers and most hospitals recognize a minor's right in those limited circumstances to make these decisions confidentially when a minor is pregnant. But that is not also a statutory right, as with contraception in Connecticut. There has been some word or effort that might be an available codified right, but that has not been taken up by the legislature yet. And there's no indication that it may do so in the future, although you never know. So the next step I wanted to talk a very little bit about, and I'm not going to spend too much time on the specifics of this, is that there is a movement afoot on both sides of the coin, as they say, to affirm the right of minors to consent to gender-affirming care, which we'll learn a lot more about from our providers and our medical experts. But from the legal side, there is some movement afoot, especially in the states of Maine and Washington, to codify this or to link it up to existing rights that minors may have in the common law, in the law that's been developed by the courts in Washington, for example. And this is a ongoing developing story, if you will. And again, a quick note of thanks to Colleen Olson, who's working with us this summer, for really being a great help on this particular issue and doing some wonderful research. On the other side of the coin, there is a movement afoot, as I'm sure most of you know, to ban gender-affirming care in states. And there have been 2 recent federal cases that have focused on adults in the state of Arkansas, and the other one slips my mind, but 2 states where federal courts have intervened and said states cannot ban gender-affirming care on a number of grounds, constitutional, equal protection grounds, most importantly. The main bill, which I'm going to highlight here very briefly, is an interesting one because it could potentially provide a template for us here in Connecticut to allow 16 and 17-year-olds to receive gender-affirming care, hormone therapy only, without parental consent. And that is a bill that's wending its way through the Maine legislature with certain stipulations, and we have the source that will allow you to take a closer look at that. So there are states that are kind of leading the way here. I don't even believe that there was a bill in Connecticut that was introduced at this point in time to provide that independent right to minors, but I would expect that this is something that could be headed to the Connecticut legislature. The state of Washington has something called a mature minor exceptions. Individuals who are treating physicians can consider the factors that I mentioned before, and there may be some way to link gender-affirming care from a clinical point of view. And again, I'm not going to get into too many of the specifics here because it's very unique and esoteric to the state of Washington. But I wanted to provide you with a little bit of background and context that there is a legal push in certain areas to expand minors' rights, at least those who can consent to gender-affirming care, and either through the statutory grounds or through the common law, through the law that's already been developed in each particular state. There have also been refuge laws that have been enacted in all of these states, Connecticut included, that prevent state courts or officials from complying with child removal requests from another state. So a minor is in Connecticut and is seeking particular care. There may be an order from another state that seeks extradition or seeks a child protection order in Connecticut, and all of these states, which are somewhat predictable, as you can imagine, prohibits state courts in Connecticut or officials from complying with these various requests or subpoenas even relating to gender-affirming care that a person, and that implies a minor or an adult, receives while in Connecticut. So this is very important, especially for folks who are dealing with youth who may be seeking this type of care in Connecticut. Remember, it's where you are, not where you're from. But it's very intimidating to work with an individual who is seeking this type of care where their home state might be enacting punitive measures at the very least, or potentially criminal actions against either a parent or a minor themselves. Okay. And finally, I wanted to just really, when I say that there's 2 sides of this coin, there's a really, really concerning side of one of the coins, right? If you want to talk about the 2-sided coin. And these are laws in red. And again, you could probably predict where these laws have been enacted, and you would have probably guessed most of them without even having to see the map. But these are states that have passed laws or policies that ban gender-affirming care. And these up to the age of 18. And again, Alabama and Arkansas, so Alabama, thank you, Colleen, for reminding me. Court injunctions are ensuring continued access to care where minors are involved with parental consent in both of those states. And the federal courts were pretty unequivocal about the right of an individual to make these decisions, in those cases even minors, because of the constitutional right of care that's guaranteed under the specifically the Equal Protection Clause, and in the Arkansas case, the Affordable Care Act. The states that you see are law or policy banning gender affirming care are being considered. So that's an entire 5 or 6 more states where legislatures may be considering banning gender affirming care. So it is a very grim landscape out there that has huge impact and potential negative consequences on a significant number of youth, adolescents, and individuals seeking this type of really critically important care. Those individuals may have the ability to travel, but it's not as easy as it sounds, right? It's not as easy to move to another state, get care for the long haul without the consequences of not being home. And that's a little bit different than a one-time procedure, for example. It is a very daunting task and can be extraordinarily traumatic, and we're clearly going to hear about that. Okay. So that is the kind of extent of my presentation. I'm going to just preview this last slides for questions that, again, I would ask all of you to put in the chat. And so we can certainly field those along the way, whether it's from the legal side or from the clinical side, which we're going to hear in a moment from both Dr. Bennett and from Ed. Okay. So with that, I am going to pass the presentation over to Alyssa Bennett, who's going to talk a little bit about her experience as an adolescent medicine specialist, pediatrician, and really what has, I think, probably transformed, I don't want to put words in her mouth, since her training in terms of a very different type of practice and practice area that is really kind of at the forefront of medicine, ethics, the law, and a whole bunch of other concentric circles. Alyssa?
Thank you, Jay. Thank you all for taking the time out of your busy day to join us and hear more about this really important topic. So good news is I don't have any slides. I know everyone loves a good PowerPoint. Jay, I love those slides, but I love questions. So please, feel free to use the chat. And Jay may interrupt me to kind of ask questions that are pertinent as they come up. So please don't be shy. I specialize in teens, so I'm pretty informal, pretty chill, and I want this to be as helpful for you all as possible. So I'm going to speak a little bit in terms of terminology to start, talk about really an overview of gender affirming care, and then talk about kind of what I do in my clinical practice that I think is helpful for everyone to know about in terms of how to approach some of these issues and topics. So terminology is really important. And as Jay alluded to, it has changed a lot over time. And I know about how it changes because I ask my patients. So I think that's really important to, to talk to teens and use, the terminology that they use and ask them to explain it to you if you don't understand. Because just like with all slang or jargon, I can't keep up with it. Like, I think I'm cool, but I'm not that cool. And my teens are the ones that kind of keep me up to date. So gender identity is defined as an individual's internal sense of gender. So what gender do you feel like on the inside? And this may differ from someone's sex assigned at birth. And so terms that we use to describe gender identity include, trans female, trans male, cisgender, cis male, cis female, non-binary, agender. There is a wide range. And again, I do rely on my patients to, ask me to share their preferred terms and explain, if there's a term I haven't heard before, for them to explain it to me. So if thinking back to maybe 8 or so years ago when I was in fellowship, patients were either cisgender or transgender. And I'd say now most of my patients who are, identify as either like non-binary or somewhere along the spectrum. And so it definitely has changed over time. Gender identity is very different from sexual orientation. So sexual attractions and romantic attractions are very different from how someone identifies in terms of gender. So you cannot assume anything. So I asked specifically about each of those. As I alluded to, transgender used to be the term that was used, and now we're kind of, I think, leaning away from that. I'm interested to see what Edgar shares with us. But often we're talking about gender incongruence or gender diversity, to really acknowledge the fact that there is a range, that it's not one or the other, cisgender or transgender. Gender dysphoria is a clinical diagnosis that describes the distress and unease that can develop when gender identity is not the same as assigned sex at birth. So that is the sometimes pretty significant changes in mood and behaviors that can happen, especially around like puberty or later on in adolescence, when someone's gender identity doesn't align with their assigned sex at birth. So my default is to ask teens what terms they prefer. And if it's a new term, so I'll have them, explain it to me. So not making assumptions based on the teen that's in front of me. I kind of ask all my teens about, in terms of gender, how to identify, like male, female, somewhere like something else, and then kind of having that conversation with them. Similarly, I ask all my patients for their preferred name. And this is just being like kind and respectful, right? Some people go by their middle name. So I don't want to call my patient the wrong name the whole time. And so patients who, are gender diverse may have a different preferred name. They may not have shared it with everyone yet. So they may have shared it with just some of their best friends and not their family. Or maybe the whole school knows and their mom knows, but not their dad or not their extended family. So having a conversation with them in terms of how they would like to be referred to it. So I have some patients that when the parents in the room, I call them one name. And when the parents out of the room, I call them by their preferred name. And also can change over time. So I like to, when I see my patients, I see them typically, every 1 to 3 months on average. So I check in to say, hey, like, is Susie still your preferred name, or has that changed? I also ask about preferred pronouns. And we have a way in our computer system that we can document all of this, that it updates everything in the computer system for patients whose parents are aware and the patient agrees to. So next, I want to talk a little about some of the medical treatment options for youth with gender incongruence or gender dysphoria. These options require an evaluation letter from a mental health provider who has experience in this field, like Edgar, for example. And there's certain things that need to be in the letter. And so the different treatment options are puberty blockers. Those can be begun as soon as puberty begins. And they're either an injection that they get every 1 to 6 months, or there's an implant that lasts a year and can be updated each year. These puberty blockers stop the body from making hormones like estrogen or testosterone. So it kind of prevents the physical changes that happen during puberty. Gender-affirming hormones are estrogen or testosterone, right? So if someone identifies as female, then gender-affirming hormones would be estrogen. And if identify as male, then they could receive testosterone. And so the estrogen options are either an injection. Every 1 to 2 weeks, there are estrogen pills, patches, and gels. Testosterone also is available via injection and gels and patches, but not pills. Gender-affirming surgery. There's different terminology for this, but sterilization procedures are right now only approved for someone 18 and older. The removal of breast tissue in some places may be approved under 18. It used to be, I think, just 18 or older, but that has changed over time. And then lastly, another treatment option that is, so I don't prescribe puberty blockers or gender affirming hormones, because my colleague in our gender program and through endocrine at Connecticut Children's does. But one option that I'm able to provide teens is different types of hormones to stop their periods if they prefer to stop their periods. This does not require a letter from a mental health provider. And as Jay was alluding to, this falls under reproductive health care. Right? So I can confidentially provide different types of birth control that can stop periods or make periods lighter or more likely to go away. Because if someone identifies as male, having a period can be very distressing. And so I do encourage discussion with parents. If there's another reason for someone to be on birth control, whether it's to help with heavy periods or irregular periods or painful periods or birth control options, pregnancy prevention. This is something that I do, in my regular standard clinical practice. And then the next part is just kind of some general recommendations for, approaching teens in a medical setting, and what you can think about if you're, supporting and advocating for youth who are seeking, who need medical care or medical treatment. It's really important for teens to have one-on-one time with their medical provider. And so I meet one-on-one with almost every single adolescent I see in clinic. And this doesn't always happen. And time is a challenge for, for all medical providers. But I do think, especially during, a teen's annual physical exam, their well child check, there are national guidelines that recommend one-on-one time. And so I explained to both the teen and their parent or guardian that, hey, this is something that I do with everyone, having that one-on-one time, and that there are certain things that we discuss that are private and confidential that I wouldn't share with, your parents unless I was concerned about safety. And so the teen hears that, the parent hears that, and then I talk to the teen one-on-one. And I'm clear with teens in terms of, when I'm asking them questions. For example, if I ask and they say, oh, I actually identify as like non-binary and I have, prefer they, them pronouns. I'm like, cool. Like, do your parents know? What do they think? Are they supportive? Because we know that makes a big difference in terms of health outcomes. And then I let them know, like, hey, I won't share this information with your parents if you prefer not to, but I'm also more than happy to help you share this information at any point if you would like. Right, because I can say I'm a doctor, right? That pulls like a little bit of weight sometimes. And so I can answer questions that, the parents may have. So sometimes I do, I am part of that process, but really I just want teens to know that I'm, that my office is a safe space, that they can share information with me and ask questions, about their body or about sex or whatever. As Jay mentioned, right, there's certain types of care that teens can access confidentially in terms of medical care without parents knowing. The ones that I kind of, experience most commonly is birth control options, emergency contraception or Plan B, so like the morning after pill, which I can send a prescription for patients or they can actually pay out of pocket for, and then STD testing and treatment. Those are the most common ones that I do that Jay had listed. There are some challenges to providing confidential care to teens. There's this thing called health insurance, and insurance companies haven't really figured out, or they probably just don't care about confidentiality and what youth have a legal right to receive confidentially. And there are different ways around it. So fortunately, Connecticut Children's understands the importance of being able to provide certain services confidentially. And so if a patient agrees to STD testing, for example, and they want it to be confidential, so it doesn't show up on the insurance, we have a way that we can bill it confidentially so that the bill doesn't go to the parent's insurance. It goes to the hospital and we cover it. It's really important. You know, I tell teens that the results are always confidential, that I would only share it with them. So I get their cell phone number, unless they're okay with me sharing it with their parent. But most of the time they want that information. With birth control, it is we kind of navigate it together, the teen and I, to kind of say, okay, here are what the different options are. Do you want to share this information with your parent? Maybe they really need pregnancy prevention, but we're going to talk about how heavy and crampy and horrible their periods are, and see if we can get their parent on board with starting birth control, for another reason. And some teens are comfortable with that and some aren't. And so I do have the ability to send, prescriptions to the pharmacy, or send antibiotics to treat STDs to the pharmacy. And I call the pharmacy and say, this is a confidential medication. They may be paying out of pocket, or they may use their parents' insurance. That's a conversation I have with the teen. And then I make sure that the pharmacy removes the contact information in the system, because otherwise I send a confidential medication and the mom gets a text. Your prescription for X, Y, and Z is ready for pickup. And then I'm like, what? So, right. And this, I kind of I think pharmacists are getting better at it since I first moved to Connecticut. So they have a better understanding. But again, I tell teens, like, I'm gonna do everything in my power to keep this confidential if that's what you are most comfortable with. But explaining the nuances of that. Given some of the challenges with providing confidential care within some medical settings, I wanted to review a few other options for teens in terms of accessing confidential care. I think school-based health clinics are such a great resource because teens hopefully are going to school. And so they're there, right? And they're there consistently. And so I've had patients who, had an STD and needed treatment, but couldn't come into clinic confidentially to see me. And so we were able to reach out to their school-based health clinic, and they were able to get the antibiotics there, at school. Planned Parenthood is a great option for birth control, abortions, STD testing and treatment, where they can provide confidential care. They have, sliding scale in terms of fee for service. And so it can, that insurance and payment isn't as much of a challenge. Actually, on 211, there's a list of different clinics across the state that provide STD testing and or treatment. And then also, just as I alluded to before, Connecticut Children's does have a gender program through endocrinology. Dr. Priya Fulwani is the head of the gender program, and I believe they just recently had a nurse practitioner join her, because she has a very, very long wait list of getting teens in for either puberty blockers or gender affirming hormones. And so they also just had approval. I think they just hired someone, a psychologist who specializes in gender diverse youth. And so that's a great resource, and I work really closely with Dr. Fulmani as well. So those were kind of the key points that I wanted to share with you all. I think Jay had seen a question in the chat.
Yeah, it I think revolves around the point you were making about and I think both of you can probably address this as well, but what happens basically, or how do you suggest providers work with patients, clients who request to be addressed by one name in the private space, but then ask that that you use another name when a parent or guardian or other folks are present. And does that happen frequently, or and how do you do that? And in a
Yeah.
it seems like a little bit of that. It's a difficult tightrope in a way.
Yeah. Fortunately, we have a great electronic health record that literally has sticky notes in it. So when I open a patient's chart, I have this little virtual sticky note in their chart, and it reminds me, patient prefers this name, and then in parentheses I put, or in capitals I put, parents not aware. And so that's a way that I remember. I also have the ability to document in a sensitive portion of the note, so that the note, isn't sent to the parent, or that the parent can't access the note, or certain confidential portions of the note from medical records. And so I think it really is figuring out what system you're using, and in terms of how you can kind of remember this, and also I think just being, open with your teens and saying, hey, I don't want to, misgender you, or use the wrong pronouns, or use the wrong name. I'm going to do my best, in terms of when I'm with you one-on-one versus like with your parent. But please, let me know if I make a mistake or an error. Just kind of acknowledging like no one's perfect, right?
One more thing, and then I'm going to hand it over to Edgar. Just something I want to put a little context on that you said, Alyssa, about this conundrum with insurance. The great irony is that a lot of us in this room work with both, mostly with kids who are insured in the Medicaid program, in the Husky program. And those for purposes of coverage tend to be a little bit easier because they're covered. There's no paper trail. There's no explanation of benefits, and there's no copays or deductibles. So for the purpose of some of these confidential care issues, that's the irony, where you have kids who are on the Husky program, which is pretty comprehensive when it comes to this type of coverage.
Mm-hmm.
But a quick reminder, and this is something I don't think we've done a good enough job doing, is there is the option for a minor to suppress an explanation of benefit for the private commercial insurance coverage. It is statutory. We were involved along with a bunch of other folks to get this bill passed, so that if a minor, for example, goes in for treatment and that is covered under a parent or guardian's coverage, it's got to be covered. The parent or guardian may not be responsible for a copay or deductible, but the explanation of benefits must be suppressed if the minor so chooses to do so. And that's an electronic EOB or a paper one or whatever it is. And I still think that this is yet to be fully realized in the community, because I think it's just kind of assumed that everybody's going to get an EOB. But and so Massachusetts did this before us, and even several years into this area, it became very difficult, and it became very clear that that doesn't answer the larger question, which is who's going to provide payment for the deductible. Say there's a $5,000, high deductible plan. Parent or guardian also has the right to look into their portal and see what has been, spent in terms of reaching a deductible or what copays. So it's an imperfect system, and I think that's why I think it's really important to keep in mind the alternatives for care in some of the clinical, spots that Dr. Bennett was talking about, that they're going to assume this as part of the billing system or costs of different labeling, et cetera. So that's just something to keep in mind. The EOB should be suppressed where the minor has that right, but it's difficult because there's a lot of other factors going on where there's a non-Husky kid who's being treated. So
yeah, and I think it also, I used to kind of share that as an option with patients in terms of the option of, conducting insurance and requesting that certain treatment is confidential. But I imagine being like 15 and calling your insurance company to be like, please don't send that thing home. Like, and I think also what response they would get. I think most insurance companies would say that's not an option, that's not possible. And then it would be done, right? So you would need to have you know, a care coordinator or a provider or someone else kind of advocating, I think, on behalf of the patients to do that. Cause I think that would be, I have a hard enough time when I call my own insurance company about anything. But can you imagine being 15 and then trying to do that and requesting that? So yes, it is. Technically, insurance companies should be able to do that, but there's so many, you know, potential barriers. So Jay, if you could like fix that in the state of Connecticut, that'd be real great.
We're on it.
Thanks.
All right, I want to we'll deal with other questions that come in at the end, but I want to give Edgar plenty of time to go through what you are going to talk about from your kind of unique viewpoint of dealing with individuals in a therapeutic environment and how this kind of plays out in a practical sense.
Yeah, absolutely. So I do have my own stuff I'm going to get to, but I do want to address this question as well from the mental health side of things, because it is a little bit different. I, for the life of me, can't remember the name of the bill, but there was a bill passed in Connecticut a couple years ago that as long as a child is under the age of 18, parents have access to their full mental health chart. So we're talking session notes, we're talking the entire intake process, all those questions answered, whether the parent was involved or not, they have access. And there are ways to suppress that. But in a sense, suppressing it kind of just signals to the parent that there's something that the kid doesn't want them to see. So the way that I approach it in a therapeutic space is I meet with the kid alone and have a very frank conversation with them. You know, you've disclosed this to me, and you've also disclosed that your parents don't know. How would you like me to address this in your chart, knowing that your parents could potentially see it at any point in time? All they have to do is request it. So that gives the child the opportunity to say, you know, yes, I want you to use my legal name, my old pronouns, or, you know, whatever they would like the parents to see versus how I refer to them in-house. And really that's, our charts do have the sticky notes too, which is really helpful because I'm at the village, we have an access staff. So we have front desk that sees clients coming in. So the sticky note allows them to know when a client is out and is comfortable with everyone using their new name or their new pronouns. That can be the sticky note in the chart, so everybody in the entire agency knows. But I do start with that conversation of like, this is the reality of things, and you do have decisions on what I write and how I write it. Because suppressing it, yeah, it can be just as much of a signal to parents that something's wrong that they don't know, which can be really tough. But going into what I had planned to talk about, I think it's really important to start with the facts of why mental health care is so important. You know, we hear about the mental health crisis that's happening, and the pandemic has only worsened it. But particularly when we're talking about this population in this community, we're really talking about higher rates of trauma, higher rates of harassment, bullying, parental rejection. Like it's a hefty list. And the Trevor Project, which if you don't know who they are, go check them out. They're amazing. But they just did a national survey. And in their national survey, they also broke it down by states. So it's really nice that we have current and accurate statistics for the state of Connecticut specifically. So within that, there was two really alarming things. One was that 42% of LGBT youth in the state of Connecticut seriously considered attempting suicide within the last year. 42 is astronomically high and higher than we've ever seen. And yes, it's higher in other states, but I think a lot of times we think of Connecticut as so progressive that the concerns don't involve us sometimes. And so this is like a really important fact that shows, you know, we're just as involved as the rest of the United States. It's still a problem here too. And then within that, nearly 1 in 5 non-binary or trans youth attempted suicide in the last year. Whether it was successful or self-aborted, it doesn't matter. But 1 in 5 attempted. And it's really important for us to be aware of that, because when someone comes in for anxiety or depression and they're part of this community, it might get overlooked as like, oh, well, it's school-based or it's parental things. And really taking in the entire big picture is super important with these kiddos. And these rates that I'm telling you are from ages 13 to 17. So it's happening young, it's happening even younger than 13, but these are where the rates are the highest. So it's really important for adolescents. And when we start talking about intersectionality, so how your gender identity versus your sexual orientation, but also race and social economic status and education and all these other factors that can come in, it just compounds the situation. So the suicide rate for Black trans women is even higher than the rates that I was telling you now. And I think Jay had a slide from the Human Rights Campaign, also an amazing agency. But Tori Cooper from the Human Rights Campaign has this beautiful quote that I just love. She said, "We're not having a mental health crisis because of who we are. It's because of how we're being treated by people who either don't understand or simply refuse to understand." And so in that understanding comes affirmative counseling. And a lot of the things mentioned in affirmative counseling can be utilized for any client, whether they're part of this community or not, but the intent really is for this community. And so affirmative counseling validates, supports, and advocates for the needs of LGBT clients, but it also acknowledges the negative influences of homophobia, transphobia, biphobia, heterosexism, getting tongue-tied. There's too many to list. And so it really acknowledges those negative influences as well as being supportive of the client and their identity. And WPATH, so World Professional Association for Transgender Healthcare, has, I want to say they're in their 8th iteration of a standards of care for transgender care. And that includes medical, that includes behavioral health, and a lot of where those two worlds collide. So much like Alyssa mentioned, you have to have a letter from a therapist or some type of mental health professional to have access to gender affirming care a lot of the time. And so WPATH has really laid out what those requirements are and what we need to be assessing for. And I think I saw a question earlier about regret and children making decisions. And WPATH really takes that into account when they're creating these standards, in that, you know, you have to have a diagnosis for a certain amount of time. You have to have talked with a therapist about it. You really have to go through a lot of assessment to have access to this type of care, which as a queer person is really annoying. To be blunt, that you have to jump through hoops just to get the medical care that you deserve. But it really does, when it comes to children, prevents, you know, snap decisions being made, because adolescents can make all kinds of decisions, whether they're good or bad. And we know this. Brains don't stop developing until you're in your like mid-20s. So this is a way to have a sort of checks and measures in place. And I did also want to mention something Alyssa had also said was about these terms and the ever-changing environment that they're in. We can look up what these terms mean. So there is a textbook definition of transgender. There's a textbook definition of non-binary. But a lot of these terms are not used in textbook ways. Identity is such a spectrum, and there's so few words to encapsulate a human experience that, you know, some people might say non-binary and it means one thing, but some people might say non-binary and it means another. Particularly like things like gender queer and gender fluid. These are terms that really mean gender expansive, but might mean one thing to one person, another to another. A lot of times trans is used as an umbrella term to include non-binary, genderqueer, gender non-conforming, gender fluid, all of these terms, but not everybody in that umbrella identifies as trans. There are people that view trans as you are either a trans woman or a trans man, and non-binary is not part of that spectrum, but some people do. So it's really important to talk to, in my case, clients, but also your family, any kiddos in your life that are going through this and expressing themselves in a way that you aren't expecting, to really ask it what that means to them, because it might be different than what you're imagining. So I had prepared a little bit that I was going to talk about how to have an affirming space at like a therapy clinic, where I'm in an agency, but I also have my private practice. But rather, I almost want to speak towards how to be affirming as a person, because yes, we can have queer magazines in our waiting rooms and have appropriate verbiage on our paperwork, and that's all really great, but you've heard those things 1,000 times. And I think it's really important to not just acknowledge that you are an ally, or even if you're part of the community, but also really just getting to know a person as a person. And it seems very straightforward, like, yes, we do that. But a lot of times, and we see this with many other groups of people, you get lumped in, you get a lot of stereotypes, and really getting to know a person one-to-one and what their personal experience is, because it's different than the rest of the community. Yes, we all have similarities, but one person's experience isn't another. And how those experiences influence, like particularly in a therapy realm, you know, like I said before, a kid might come in for anxiety and their identity has nothing to do with it, but a kid might also come in for anxiety and it has everything to do with their identity. So really getting to know them on a personal level is absolutely key. And then I wanted to share a couple resources as well that are just amazing. So I had mentioned the Trevor Project. There is also, if people are having a hard time finding gender affirming therapists, there's a website called Therapy Den. And this website has really pushed to be gender, sexuality, just really LGBT inclusive in the way that they lay out the website. They give the therapist a way to identify whether they're part of the community. It immediately asks for pronouns. It does like a lot of micro affirming things. So it's a really good place to look. I feel like most agencies, like bigger agencies, now have dedicated queer services. And then there's also, specifically for Connecticut, there is a place called Anchor Health. I want to say they're located, I know they have an office in Hamden, but I think they're located in a couple different places. And they have developed an entire like spectrum of care, like a master list almost of all of LGBT competent therapists, primary care providers, gender affirming surgeons, sexual health care. They also do case management. They do some stuff in-house as well. It's a really great resource if someone is coming to you and saying, you know, I want to go forward with gender affirming care, and whatever that means, whether that means therapy, whether that means medical, they're a really great source to go to. This is what I need, and they have answers. They're an amazing program. So I will step back from my soapbox a little bit for a minute and answer any questions that you guys have, whether it's about something I spoke about or just gender affirming care in general.
Before I get to the follow-up on that, I wanted, Alyssa, if you had a, I think there's some perception or misperception that gender affirming care is something that's, you know, kind of arbitrary, or it's, you know, kind of done with, you know, and I think, Edgar, you pointed out appropriately and thoughtfully about the criteria that are necessary to even engage in that. But from a clinical perspective, Alyssa, I know that this is a very highly tested and researched and peer-reviewed area of medical practice. And I know that this has been said a number of times, but I'm hoping you could kind of reaffirm that in a way from the clinical side as well.
Yeah, so Edgar had referred to, you know, the double WPATH guidelines. And again, there's, you know, numerous updated versions of this where these are medical and behavioral health evidence-based guidelines in terms of how to diagnose, you know, gender dysphoria or gender incongruence. What are the, you know, treatment options? What are the risks? What are the benefits? And those of us who, you know, provide gender affirming care, or, you know, support and refer patients for gender affirming care, this is a very thoughtful and, you know, planned treatment option. That's not especially for, you know, minors, for under 18, right? You can't just like show up in someone's office and say, hey, I want to start, you know, gender affirming hormones. And they're like, here's your prescription. That's not how it works. It would be nice in some ways, but there are certain steps that need to happen because we want to make sure that, you know, we're providing the best care possible and whatever that looks like. So there's, you know, a lot of education that goes into this, right? Educating patients, their, you know, parents, legal guardians, caregivers. It's not something, you know, right now that a teen can access on their own, a minor can access on their own. It's looking like that may change in different states and over time, but for right now, it's not. And we also have lots of outcomes in terms of when we provide this medical treatment, in terms of gender affirming treatment, whether it's puberty blockers or gender affirming hormones or surgical procedures, that the outcomes are impressive mostly in terms of like the mental health outcomes, as Edgar shared, right? For patients with, you know, who are, their gender is not aligned with their assigned sex at birth, it can cause significant distress, unsafe behaviors. And I've seen patients like, I want to say transform before my eyes, in the sense that when I first meet them, they've had probably lots of negative interactions with medical providers, and they don't feel comfortable in their bodies. And then they start receiving treatments and they like come out of their shell a little bit. And it's like, I'm meeting them for the first time. And it's so, so cool. And so yes, these are, just in summary, these are very, very thoughtful, researched, evidence-based guidelines, and not just like throwing hormones out to whoever is like, this is how I feel today. It's not how it goes.
Yeah, I think that's been I think that's been reiterated several times, especially over the past several months by folks around the country who have really kind of devoted their care to this particular area of specialty. Robin, thank you for that question. It's a really good one. I'm going to give Edgar your first shot at this one, which is for smaller agencies and providers, what would you suggest to improve the overall awareness of or sensitivity to gender diverse clients? Really thoughtful question. I want to see what your thoughts are on that.
Absolutely. I think first and foremost is education, whether that's bringing in an outside trainer, whether that's finding trainings or continuing education online. There's a lot of great ones. I think even things like Simple Practice are putting out trainings. I know here at the Village, I was recently just approved to do a bunch of in-house trainings on this topic. So I think that would be a good step one, is just building staff awareness. It's also really easy to modify your language to be more affirming and more inclusive, whether it's needed or not. I mean, it's good to go in without assumptions. So starting things like asking every client their pronouns during intake and documenting that and having it in your paperwork. Yes, Nate, Q Plus offers trainings. They're another organization in Connecticut as well. Another way to be affirming is, updating that paperwork. So not just pronouns, but also having, identified sex at birth versus gender identity, and having those be separate questions so that the awareness is there and there's no assumptions made. Also, something that's like really micro affirming is when you do have those questions, have a blank instead of listing options. Because if you're forcing someone to mark themselves as other, or mark a term that like kind of identifies them, but it isn't quite what they use, that can be really off-putting for a lot of people too. Nobody wants to be seen as other, and that applies to gender and sexuality, but also to any other demographics that we have. So little things like this can be really powerful and have big impacts.
Any thoughts on that, Alyssa, from your perspective, or no? Nope, you're good. And muted. So good time to mute. All right. I wanted to get your thoughts about how this plays out in a little bit of a different forum, but still may be connected to your either practice, clinically or therapeutically. But what comments, and I know there's some folks on this webinar who are involved in school education, educational resources, or provide support to school districts. But how have you, what are some of your impressions on how kind of gender identification, some of the individuals with whom you're working have found this as navigating the school system, navigating their daily trek, because the main touch point for every youth is school, obviously up until the time they graduate. That we always say in our world, the two main touch points for every child and youth are school and the health systems, right? Those are necessities. They're always going to intersect. But how have you found school systems to be in terms of receptivity, in terms of providing some of the same things you just talked about, in terms of trying to improve overall awareness and sensitivity, and how has that played out, at least in terms of in some of the patients that you folks have seen?
So Jay, you already know how I feel about this. I think the first time we met, I asked you how many trans kids have to die before we make changes. And I know that that's a really blunt statement to make, but the way that the Connecticut school systems, and I'm sure in every other state too, is that there's this surface level of protection, especially in Connecticut, you know, it's discrimination. And if we're not using the preferred name and pronouns, then that's discrimination and we can't discriminate. But there's also really deep layers into if a kid comes out at school, but their parents don't know, under FERPA, it can be really interpreted differently by different people. And so it's really up to the judgment of the teacher or the school nurse or the school counselor, what is considered part of the educational record and what they can or want to or don't disclose to parents. And it's really a shame that Connecticut doesn't have a set of guidelines for this yet. And I know we're like working towards it. But school is really viewed for a lot of children as a safer place to test the waters. You know, they might come out to a trusted teacher, or they might come out to their friends, and they might ask like, hey, can we use different pronouns during this class? It's a really supportive environment in a lot of ways for kids to test things out before going to their parents, which can be really scary. But the confidentiality and the things that they get from therapy and coming out to a therapist, they don't get at school, even though a lot of kids perceive it that way, that they do. Like, oh, well, I told a teacher, but they're never going to tell my parents, so it's okay. But in some cases, if a parent were to ask, it's a good probability that the teacher would have to tell them because of FERPA. So it's a really strange climate schools are. In my experience of working with schools, for the most part, I do find most of them are really affirming and want the best for the kid and want them to express themselves. But it does get in murky water with confidentiality.
I don't know if you want to add anything to that, Alyssa.
Yeah, more that I agree in that school can be a safe place to experiment and test things out, not in all respects, right? Not just gender, but sexuality and style and hair, you know, and all the ways that teens express themselves. Right, you like wear one thing when you're leaving the house, you change into the real clothes you want to wear when you show up at school, right? Like, who hasn't done that before? So I do think that in general, a lot of my patients do feel supported in kind of expressing themselves at school, but obviously more, you know, more work to be done.
Yeah, and to piggyback on that just for a second, I think what Edgar alluded to was that there's a bunch of folks who are on a working group to really provide a real push to the State Department of Education to articulate a specific set of guidelines to do exactly as I think, as Edgar said, to protect individuals who you know, would like to kind of affirm their gender identity, and how is that guarded as confidential and potentially not shared because of this kind of confusing overlay of the federal Education, you know, Privacy Act, FERPA, and I think we have found, again, without getting into too many of the weeds, some really good guidance from some other states that had been really proactive about this, in New Jersey in particular, and a couple other areas. And we proposed they really, what we thought was a really thoughtful set of guidelines, and sent that to the State Department, or at least sent it to some colleagues in the legislature who we were hoping would maybe take a bit more proactive stance this past session, and it did not happen. But we are still waiting because there must be a lot of back and forth for the newer guidelines that the State Department had promised, and those have yet to be published, and they're hopefully forthcoming. But unless there's some kind of cavalcade of change, it's not likely these are going to be as powerful and protective as they potentially could be, but we'll have to see. Couple more. One question was, and I don't know if these resources would be any different than the ones that have come in on the chat, but resources for parents and caregivers. Are there other kind of sources as opposed to providers, or of some of the stuff we've talked about and that have been indicated in the chat? Health edu, health education org, and some of these other resources, Q+, et cetera. Is there something that's more dedicated to parent and caregiver education and access, that kind of thing?
E-Flag is amazing. They are specifically for parents and caregivers, and they do a lot of education, but they also do support groups so that parents have a space to speak with other parents that are going through similar things that they are.
Yeah, agreed. And a lot of these websites have, resources for, professionals and for parents, and, they have different options, or they refer to other resources. Jay, I just saw some comments in the, some questions in the chat that I wanted to address. Is now an okay time to do that?
Please go ahead, at your, at your discretion.
Yes, so there were some questions about, long-term effects of like birth control and hormones, and the role in terms of parental involvement in kind of making these decisions in terms of hormones. So for in terms of birth control options to suppress or stop menstrual periods, very safe. These options have been around for years. There's no actual medical reason to have a menstrual period when you're on hormonal treatment that prevents them from happening. So very safe medically. There's lots of evidence to support that. In terms of puberty blockers and gender-affirming hormones, that is not a decision that a minor can make without parental consent in the state of Connecticut. So I just wanted to clarify that these medical treatments are not being done behind anyone's back. That's not an option. And so it is at a medical visit with the teen and parent or legal guardian, reviewing the risks, the benefits, short-term effects, long-term effects. Puberty blockers are reversible in the sense that, they stop the body from producing estrogen or testosterone hormones to prevent, puberty from progressing. But when you remove them or stop them, the brain continues to send those hormone signals to the ovary or the testes, and those hormones can be produced. So it is reversible. Gender-affirming hormones have some side effects that are not reversible. And so that's part of the discussion in terms of the medical provider having with their patient and family, just like any other treatment, right? If someone has diabetes and needs insulin, this is a conversation that's had with the teen and their parent. And so I just want to provide clarity on that.
Yeah, thank you. Did you want to say something? Because I just had one code. I had one code on that, but I'll give you the next word on this.
Yeah, I just wanted to also add that I know I mentioned a lot about confidentiality and not being out to parents. Even in the mental health space, here at the Village, we strive to do family therapy with every client. So if a client is coming in with these issues presented and a parent doesn't know, it's really our jobs to work with the client and work with the parents to build a better relationship and building stronger families so that they have the space to bring these topics up. Just like Alyssa said, that these aren't decisions that are made lightly and are decisions that aren't made with parents. There are made with parents. So even if a child's not out yet, we're not in a position to help a child access gender affirming care without a guardian's consent. Just like Jay had mentioned, all these other things that minors can't consent to, they can't consent to gender affirming care in the way that the question was asking about.
Right. You know, I think that's important to remember, and I think you both articulated it far better than I, that, you know, that's the state of the law. There's no availability or legal capacity for minors to consent to this without parents or guardians as part of that process. So there's two sides. Again, you have the legal side, it's just not going to happen. That's a fact without parental involvement or consent. And clinically, there is a body of medical evidence that is overwhelming and peer-reviewed, because that's the way we practice medicine in the United States, that contradicts this notion or idea that there's you're going down a pathway that could be, you know, extraordinarily harmful or detrimental. It's the same arguments that we hear for statutory rights that have been in existence for 50 years. That minors have had the ability to access this confidential care, but yet there's this kind of theory that somehow it's not clinically appropriate and that there is some end run around parental rights, and that the legislature has considered these areas extraordinarily carefully and have done so with appropriate debate and open ability to express you know, discord or even opposition. So that's kind of where we're at now. And if that comes up in the future, I'm sure that will be available for both the clinical and the legal discussion. Good. I want to give either of you or both of you the last word. If you have any new epiphanies that you've thought of in the last few minutes. Before I do, though, I want to thank both of you for really thoughtful and really kind of providing really helpful guidance, even to those of us who have worked with individuals over the years, but in a way I think that's both refreshing and it encourages a kind of an optimistic viewpoint forward. If you looked at that chart in the body of slides, you might be pessimistic. But if you also look at the people who are working in this field on a daily basis, you can't be anything but optimistic, because both of you are, I think, evidence of real kind of frontline caregivers who are working with this incredibly vulnerable population, but who have really thoughtful guideposts and mentors and clinical friends. So I want to thank you both for the work that you're doing, for the information that you provided, and for the guidance that you gave us today. But so with that having been said, I don't know if there's anything you wanted to conclude on, and then I'll have one last word.
Yeah, so I think I said at the beginning of my presentation, but just to kind of, I think most important is to, treat everyone with kindness and respect, regardless of what you believe or what they believe. And the other thing is that and again, I'm working from home, so I don't have my all my work gear, but I have a rainbow lanyard that is part of my Connecticut Children's lanyard. And it's a way for me to communicate quickly to my patients that I get it, in the sense that I'm here to support. And I've definitely had patients and some parents who they immediately notice, right? And so if you can find a pin, right, like an LGBTQ or rainbow pin or pride at something, or have it posted in your office, right? Like, teens are looking for them. And when they see it, I can just imagine them like taking a breath. And so yes, thank you all for your questions and for your attention today. Edgar.
Yeah, I have the exact same experience. I have a lot of different pride flags and different rainbow things in my office. And all the time, like during intakes, when I'm first meeting clients, they'll be like, oh, I love your office. And then as soon as, their parents are out of the room, or if their parents do know, I love that you have pride flags up. That's great. So they are looking, and it's so easy to signal like, yes, I am a support. I am here for you if you need me, by just simply having something in rainbow. It's really beautiful. I love working with this population. It's great.
Excellent. We will be sending out the slides and the link to the recording for all the folks who are registered. I think we've probably been able to collect. So the last question, which is, would we be able to send out the resources? Hopefully we've been able to capture most of those links, and we can send it out in the potential email as well. So we will try our best to do that, Aisha. So thank you for that question as well. I have some thanks. A couple of folks from my colleagues, Brianna Wall, who's been the kind of technical person who's been running this webinar. Thank you, Brianna, for all your help and assistance in getting all the info out and the links and taking care of all the ineptitude that I traditionally display. So thank you for that. And of course, Stacy Violante Cote, who you can see up in the top row, is a longtime colleague of mine, and it really puts our training regimen together. So thank you, Stacy, for keeping me on track and target and getting me to do all the things that I needed to do as well. And Colleen Olson, who again, I want to thank for all your hard work and providing some of that background legal stuff. And we're available here at the center if you have any questions from the legal side. Don't hesitate to reach out to us. We work in our Connecticut Children's and our New Haven sites, our Yale New Haven and the Yale Child Study Center. So, and of course, our work with DCF on a regular basis, and be happy to provide any guidance and counsel as best we can. So with that, I am right at, I think, right at 2:30, and that is just perfect. And so thanks to everyone again for participating and for registering, and enjoy the rest of your day and the rest of Pride Month as well. So thanks again.